carry this with me. I don't like to stand behind podiums, okay? So usually I'm out. Now there's some new faces, so I'm glad to see you, okay? And those of you who came back, I'm glad to see you as well, so thank you for doing that. What I wanted to talk about this afternoon is the lessons that were learned when we established the NCNR and later the NINR. And the reasons I wanted to do that is because it was a big lesson for our profession in terms of what it took for us to accomplish a major goal, a major legislative hurdle that we overcame. And how did we make that happen? Because as we now move into the time of needing to have more scope of practice for our APRNs, okay? And we need to get more nurses in leadership positions across the country, which we've got a number of them right now. How do we go about doing that? As a profession, what were the strategies we used in the earlier days when we established the NINR that then we might think about using now, okay, to put together now? And so that's a piece that I really wanted to have a chance to talk about and to get your questions and your thoughts about as we go through this in that sense. It is, in fact, a time to celebrate. The National Institute for Nursing Research as a national center was created in 1986. That's a little more than 25 years ago now. And tomorrow I'll be talking about a lot of the research that has been generated, and particularly a lot about the research programs that we've had over the years that have really, in possibly 2 decades of study, our senior scientists have really beginning to make a big difference in health policy, in practice procedures, practice protocols, and that's really a very small amount of time. When I went to NINR as its first director in 1987, they have already celebrated their 100th birthday. So to give you some sense of how young nursing research is, and yet in my mind, how much we've accomplished, how quickly. Now, how do we help to continue that advancement? How do we help to get more and more of the kind of leadership that we need, the kind of resources under nursing research and under nursing programs, APRN legislation, et cetera, that we're going to need to really move with this new healthcare reform movement? Because we're going to be central. And so we're going to have to step forward and make that happen. Nobody else will make it happen for us, believe me, in that sense. So if we think about the creation of the NINR over 25 years, and the lessons that were learned in that legislative process, because it took us relatively few years to move into a national center and then a national institute. And to consider then what we might well be wanting to do for the next legislative endeavors we're going to need to undertake. This is really what I call a health science policy story. There's health policy, which are all the kind of documents that occur either at the organizational level and in practice of patient care policies and protocols, or occur at the state level with legislation that passes and policies that get put in place by your Department of Health, or at the national level, which occurs with the National Department of HHS policies. So health policy happens at all levels. What is science policy? Science policy is really that policy then by which we set the directions, the idea of what needs to be resourced, reimbursed, studied, and because of what we choose to study, we will then have the research to influence the policy. So it's kind of one step back, but it's a very important step back in that sense. And quite frankly, the NINR was a big change in health science policy for NIH. Certainly big for nursing, but it was also big for NIH. And the reason of that is because we bring a very different disciplinary perspective. We don't think like docs do. Thank goodness we're very complementary with our physician colleagues in the way we think and what we think is important. but we don't think the same way. So we ask very different questions in our science. And that has become very obvious over the 25 years that the NINR has now been in existence with the NIH. We have a focus on patient-centered care, not on diseases, okay? Our focus is not on pharmaceuticals or on surgical interventions. It's on people, self-management, issues about health promotion and risk prevention, risk management, etc. All of that is a very different perspective. So we immediately brought to the NIH a very different way of thinking about not diseases, illnesses, and how people manage and cope with their illnesses. And as soon as we began to ask those questions and put out those kinds of application RFAs and RFPs out there for people to respond to, we had all kinds of colleagues on board with us. People from Heart, Lung, Blood, from Cancer Institute, from National Institute on Aging, all of the institutes who wanted to help us fund different kinds of research. Because for them, it was exciting, important research, but it was definitively different than what the NIH usually asked for, okay? So we made a big difference quickly in the way that science policy is viewed and what all it contains at the NIH. It's kind of fun to think about that. I don't think any of us did when we went into it. We were kind of trying to get nursing research started, thank you. If we could just get our head above water, we would be happy. If we could just figure out what nursing research was and what all we could do with it and get it funded. So it wasn't until we looked back later, after a period of time, that we realized the change that had occurred in the institution itself and in the science policy area itself, health policy area itself. Clearly, these are other disciplinary perspectives that are big for us, and all of them were different. Today, as you know, the NINR is the lead institute on all end-of-life research. So end-of-life research, considerations of quality of life, how we work with that as professionals, with families, all of that has been essentially considered now nursing domain in that sense. We take the lead, we help define the questions, but we always do it with a number of colleagues from the other institutes because nursing is by nature collaborative, right? So it makes our science much stronger, and it frankly makes our funding base much stronger because that way, if we only have so much money to fund something with, but aging wants to also fund the same thing, we just double the amount of funding that goes into that, okay? So those are the kind of politics, the kind of issues that were very important to us as we moved into this. But we made a big difference. We literally changed the landscape in that sense. Now, one of the questions then, as I looked backwards on it, for me, was how did we manage to make this happen? Now, I'm sure our colleague who was at ANA can also speak to this, but it was a lot of work, a lot of investment of resources, particularly a lot of unification by our associations. Not something we'd always done well, or not something we'd always had as well programmed with each other. So how did we go about that? And what I'm going to do first is put this in context. I warned you earlier at the earlier meeting that I always have a model for something, okay? And put something in context because it helps me understand it, helps me to be able to analyze it, to figure out what happened, what we can do again with the same idea. And the model that I used here is the one that's from Kolachek. Feedham and Meister have particularly adapted this model in for nursing, and a lot with family nursing. But three components that you think about is the knowledge and information you have available to you when you're trying to build or move a policy issue. So think about a policy issue. You and I want to establish an institute at NIH. That's a policy issue. Can we do it, and how do we go about it? What do we have to think about to make it happen? The second big piece is a major one. The political will is probably the critical issue. Can you get the buy-in from all the stakeholders? Will they all be excited about this with you? Or are you going to have some groups that will say, oh, we really don't need an institute? Now, I can tell you from the years I've worked on Capitol Hill with the Congress people that I have had them literally say to me, if in fact you all can't decide what you want, then I'm not going to decide for you. So if you come in here with 3 different stories from 3 different organizations, I simply listen, smile, shake your hands, and tell you goodbye. They are not going to do a thing, okay? You have got to be unified. And if you're not, they are not listening. Now, everybody doesn't have to be unified over every issue, although you'll see here we were able to do that. Who doesn't like research, okay? Or didn't think research was important? I mean, this was a big deal for the whole profession, okay? So it clearly was a part of all of us. But there are times when there will be a particular issue that's more oncology, nursing, society, and nature, or more APRN in nature, et cetera. And in that case, it's important that all the APRN organizations are saying the same thing. That's what I mean by the unity kind of idea. But political will is a big issue. How many constituents can you get behind it? How clear can you make the issue to your congressman? How obvious can you make it that anybody who votes against it is going to be in trouble in the next election? Okay? Those are the kind of things that make a difference. 1 out of every 16 voters is a nurse. Okay? And that's something that you can use very well. Okay? That's a lot of power. And nurses vote. And women vote. So half of those other 60 probably will never go to the polls. Okay? What?
1 of 60.
Uh-huh. Yeah. That's the figures we had at this time. Now, we should look now because we've got more nurses now in the systems. So it's probably even higher at this point. Yeah. So don't ever forget the power we carry because of that voting capacity, okay? Now, we don't use that blatantly. We use it quietly. But that's okay. That's okay. Okay? We can do that very nicely behind closed doors on a one-to-one. Those kind of messages get done. And the last one, of course, is the social action, what actually occurred. And in this case, it was the legislation for the NINR. This just gives you some of the background for what the model stands for. The knowledge base is really, what about nursing research could we tell people? What could we bring out about nursing research that would make a difference, okay? If they could tell that the research that we do is going to make a difference in changing health outcomes for patients, that's their constituency, okay? Never, and what we did for years is nursing, never talk about yourself. You're not there to talk about nurses. As soon as you do that, that's a vested interest argument, and they turn off. Congressmen turn off, okay? Talk about patients. Talk about the clients we care for. Talk about their children, and you can get their attention every time. It's a big, big issue for them, okay? But it's an important thing to know that that's the way you need to approach it. Now, our problem in this case was in 1985, we didn't have much knowledge base, okay? So I'll show you the policy studies that helped us to get the legislation in place. But it was not nursing research, which is a very interesting thing. People actually voted for the NINR, or the NCNR. I always call it NINR now. They actually voted for it without knowing what nursing research was for other reasons. So we'll talk about that. But that was a very interesting piece for all of us at that time. The political will, of course, is all your stakeholders. It's all the interest groups. It's all the people who have to be on board with you. It's all of them who have to be giving the same message on the same song sheet, etc. All those kind of statements. Very, very important in that sense. But that is a very, very critical piece. And the social action, then, is the actual program or legislation that you're trying to put in place. So what I'm going to do first is take you through quickly kind of what happened with the legislative process. Our friend from ANA may want to speak to this. It was a lot of fun. The process began in the summer of 1983 when the Legislative Affairs Office at the ANA had the opportunity in talking with one of the congressmen and their staffer, Ellen Riker. This was Congressman Madigan, Edward Madigan, a Republican from Illinois. And Ellen Riker thought that her congressman would be interested in putting something forward for this legislation. And the question was, do we want to try for it? Now, there'd been a lot of talk about some kind of institute at NIH for a number of years. This was not a new idea for nursing. But we needed to have then some actual action with it. And we, of course, had one of the 1983 Institute of Medicine study, the IOM study, that said clearly that nursing research needed to be established within the mainstream of scientific investigation in the country. Okay? That was the biggest piece that we had really going for us, because this independent group looking at the future of nursing, what it needed to be able to really move forward and continue to develop as a profession, said clearly, we need this research institute. Now, they didn't say NIH. The IOM would never be that prescriptive, okay? They just say that it's needed. Nursing immediately said, aha, NIH, okay? And so they began to work with Congressman Madigan. So in the fall of '83, he introduced the legislation to amend the NIH reauthorization. Now, in government, you authorize legislation and you appropriate money for what has been authorized, okay? So there are a whole series of authorization committees and there are a whole series of appropriation committees. In this case, we were working with the authorization committees, and they were interested in creating a National Institute of Nursing. Congressman Madigan was on the Ways and Means Committee, which is what puts forth legislation in that area, and is the committee that's responsible for handling the reauthorization for NIH. In November of '83, as you can see, that amendment passed the House of Representatives really fairly quickly. We were all surprised, to be quite honest. In early 1984, we began to get the red herrings, okay? You always get red herrings. When you're in a political process, somebody will try and divert you. So keeping your eye on the goal is a major, major kind of thing that you have to be aware of. Don't let somebody lead you off in another direction because it sounds good, okay? In this case, the people who didn't want a national institute at NIH, and that was NIH. It was the medical community and NIH that did not want one. They had gotten Senator Orrin Hatch, who later turned out to be a really good friend of the Nursing Institute, okay? They had gotten him to put in counter legislation. What they'd do would be create a bureau of nursing, not a division of nursing. That was a big thing for the whole profession. And this would be a center of nursing research within that bureau. Well, you can imagine, I would like to have been a little mouse on the floor to have heard the ANA discussion at their next board meeting with that. Because that was a big, very big carrot to give to nursing. Take it from a division, make it a bureau. We'd have research within it. To their credit, they never faltered. Leaving nursing research within a health manpower organization, which was the Bureau of Nursing, and the Health Services Resources Administration, left it in a place with no growth. We had had $3 to $5 million for nursing research for years. That was the whole country, okay? Today we have 146, to put that in perspective, and that's not enough. But you're listening to a biased person, okay? So I will tell you that up front, okay, very quickly. But in fact, that was a big carrot. And to the credit for the ANA and its board of directors, it said no. They said, if you want to create it, fine, be our guest, create it. We are not acting on it, and we are not filling the positions for it. Pretty hard-nosed. They were tough politicians, let me tell you, okay? Now, the two bills resolved themselves in committee with an NIN. It was actually National Institute of Nursing at that point, to go to NIH. But they were vetoed by President Reagan at that point. And that was a closed Congress, so there was no way to come back and do anything with it, okay? had to be recreated. The legislation had to be put back in, and that was done then in the fall of 1985. Okay? In October of 1985, the two bills were reconciled between the House and the Senate, and in conference, and as you can see, that then went on to the White House. At that time, Senator Dole had looked carefully and talked with Reagan about the fact that if they sent this bill on with a National Institute and a New Arthritis Institute, there were two of us trying to get developed at that point, would he okay it? And he said yes. So the fact that, or National Center, excuse me, at that point, the fact that he then vetoed it in November of '85 when they sent it forward made them all mad. It was a different kind of Congress then. A different kind of people playing. And frankly, the bill then went back through with both the Arthritis Institute and the Nursing Center in it, and literally passed both of the houses, the House and the Senate, with huge majorities. There was something like 92 to something in the Senate. It was amazing. It was very high. But the congressmen were mad. They thought they had a deal. He reneged on the deal. They said, you're not going to do that to us. And they voted it in. So the National Center for Nursing Research was created then in April 16th, 1986. Now, how did we get it? How were we able to get this started? Having given you the overview of the legislation, how were we able to get Congressman Madigan to do this? One was the influence of the IOM report. That was a major piece for nursing in making this legislation move, okay? Because the IOM, how many of you are familiar with the IOM? Okay, most people are then. Because this thing, it's a big policy developer for the federal government. And in healthcare, it's listened to big time when they make a recommendation. Some of us who were in this process are divided on whether Ellen Riker was or was not a nurse. Jan Heydrich says she wasn't. She was with the ANA Legislative Affairs. I thought she was, because she and I had a talk once about nursing and some things that her work in it. So I thought she was. So I don't know whether she is or not. But he clearly had a health staffer, a top health staffer, who was, quite frankly, really interested in nursing and really interested in creating something. Now, anytime you go to see your congressman, look at who staffs the health area, because that's who you'll be talking to. If this is a 21-year-old who is just out of college, who has almost no experience on the Hill, this congressman is not real interested in health, okay? If, in fact, you're working with someone who's been there a while, who is experienced, this congressman is interested in health. So you can get a perspective almost immediately on how well you're going to be listened to and how well they will be able to convince the congressman something ought to be done. If, in fact, you know you've got a young staffer, then what you do is set up a time through your full university to actually see the congressman, okay? You don't talk to the staffer again. Take care of that one, get it off the document, go directly to the congressman, okay? But you have to understand those kind of things about the way the Capitol works, okay? Capitol Hill works in that sense. Madigan was angry at medicine. He had had a bill in with medicine, and they stabbed him in the back from his perspective. They decided at the last minute not to follow through on it. He'd put a lot of work into it, and he was mad. So with him being mad and Ellen Riker being really interested in nursing for whatever reason, Riker then contacted ANA and said, I want to talk. And they wanted to talk, okay? And that's how we actually got this started forward. It's interesting how things line up, okay? It is not because we're good guys or they knew anything about nursing research, okay? None of the above made any difference, okay? Which is interesting. Now, there were several studies that did make a big difference in this as we went through, and they're policy studies. They're not nursing research, okay? But they're very important policy studies. First of all, we've spoken about the Institute of Medicine study, in which the recommendation for that was very clear, okay? And that came from the Institute of Medicine, which is well listened to. There were several other studies. One was one that was done, or it was commissioned by the Assistant Secretary of Health. Now remember that recommendation that in fact we create a Center of Nursing Research within the Bureau of Nursing? That's where this one came. That's where that recommendation came from. It was put together by the Assistant Secretary of Health because they didn't really want to proliferate any more NIH institutes. So they did a lot of interviews, created that study, which in fact gave a different recommendation to try and stop the NCNR, okay? And the profession said, thank you. We're really glad that you're looking closely at nursing and nursing research. No, thank you, okay? They just kept right on moving for the NIH. The NIH task force then was put in place by the director of the NIH. That was James Weingartner at the time. It's the gentleman I started working with. And that particular task force was to see how much nursing research is already being done in the NIH. Weingarten told me later at a cocktail party, you learn all kinds of things at cocktail parties in D.C., that in fact, he thought there was quite a bit of our kind of research being done, and we really didn't need a new institute to make that happen. Well, what came out of this study is that actually, out of a multi-billion-dollar budget for NIH, less than $1 million was committed to nursing research. Okay? The profession took that. The ANA did marvelous things with that. I mean, they had it all over the materials that we were taking to the other congressmen to get the NCNR in place, because that showed definitively, no, we weren't represented, and we needed to be represented, okay? So that one backfired, to say the least. And the fourth study was one that Reagan was waiting for when he vetoed the NCNR the first time. It was commissioned, I think, by the NIH itself. And it was another IOM study, and they were looking at the proliferation of NIH institutes. Now, I don't blame them. There's over 29 of those now. I mean, this is really a tough organization to manage because of the scope of the organizational structure. Now, the IOM, what they wanted was a recommendation from the IOM that no more should be committed. The IOM never takes a stand like that. It always dodges those kinds of questions because it's not a political body in the sense it's got a lot of political influence, but it's not a political body in the sense of telling the politicians what they ought to do or not do. So the IOM simply said, got to be careful about how many institutes you get in place. Here are the kind of criteria that you need if you're going to be an institute, okay? So be compatible with the research and the research mission, training missions particularly. The research area to be supported is not receiving adequate support. Remember the study we just talked about before that showed less than $1 million in nursing research? The field to be studied shows potential for scientific growth and funding. Well, you can imagine the ANA and the Tri-Council had a ball with these. They just had a ball. They were right down their alley. We could take every criteria and make it fit for us for why we ought to be in a center or an institute, okay? So it was fun to get this study out, you know, and it was not fun for NIH because they had hoped for a different answer. But it set up beautifully for us in that sense. Now for political will, here's the piece that ANA and the Tri-Council, because they were working at that point with the Tri-Council, which, as you know, is the College of Nursing group and the Nursing Administration Executive group, okay, and the NLN. So between that and ANA, why a quad group has always been called a Tri-Council, we'll never know, right? It's what? 4 councils. Yeah, it's just ridiculous. And it's always been called the Tri-Council. We've always kind of gone, what? Okay. Well, it seems to work for them, so we don't say anything, right? But it is the 4 groups when it's called a Tri-Council. But the thing and ANA was really the major leader on this the whole way through. They were really the ones who stuck with it all the way through. The main thing was unifying the profession. In 1983, when this was first proposed, the nursing profession was in chaos. I have to tell you, many, many of our major leaders did not want this thing to happen. They were scared of what happened if we got a national institute or at NIH, would we lose the educational mission in the Division of Nursing? Would we lose the money? Well, today we've got, what, almost 150 in research and over 250 million in education? I don't think so. And literally, it was the young Turks on the block who were saying, no, we got to do this. This really needs to be done. If we're going to move research at all, it's got to be in the mainstream of scientific investigation. You can't move research when you're setting someplace else. And they were absolutely right. I mean, NIH was critical for our science to really move. So it took us about 12 months, I think, maybe 9, to unify the profession. And every one of us who were on the cabinet of nursing research at that time were spending our time on the road. I don't think I've spoken at so many conferences in one time period of my life as we did during that period of time, because we had to bring all the profession around to believing that this is something we really need. But it happened. When we were finished, we had all 4 of the Tri-Council groups on board with it, and we had 75 of the specialty organizations signed on. Nobody went on the Hill who did not say to a congressman, we need a National Institute of Nursing Research. And why? And here's some examples of what it will do. They were a little sparse, but we had a few examples, okay? But that was critical to have that in that sense, okay? We also had to define strong legislative champions. You have to have somebody who's really in this with you that's a member of the Congress, that's part of them. That was Madigan in authorization for the House. For the House and Appropriations, it was Purcell from Michigan. He was the other one. When they moved to the Senate, we had Inouye, who's always been behind us no matter what, Kennedy, okay? And so we had a number of people who were really with us in that sense. Now, it was the Cabinet on Nursing Research who was at that point when we started, chaired by Noel Pender, who really was instrumental in helping the ANA board. Because that board, they weren't researchers. They were phenomenal people in terms of understanding what was needed. I will be forever grateful to that group of people who had that kind of vision when they themselves really didn't have the knowledge and really weren't part of that. Eunice Cole was the president at that time. She was very strong, good speaker, good representative, and did believe in. She was CEO for one of the University of Washington hospitals, wasn't she? If I remember right.
She was actually
From Bellingham? Okay, thank you. I'd forgotten that one. Thanks. But she was very, very strong and very, very helpful for us, okay? So all of this went together in a period of about 12 months. So by the time the legislation went through again in 1985, just 2 years later, why the profession had its act together. And it was giving the same message on the Hill with these same examples. And they were very, very well coordinated, which doesn't happen often. But that was one of the big lessons that we should learn, or should have learned in that sense. Okay. Now, we had one major problem through this whole thing, and that is that we did not let NIH know we were going to do this. You won't ask permission anyway. You're not about to ask them if they can do it. You know what that answer is, okay? But you do need to let them know. And for a while, when we first arrived at NIH and began to try and make inroads, that was a problem, because there were some not good feelings about the fact of how we come in, okay? They would have been a lot better had we told them up front. And you'll notice when we redesignate to an NINR that we did exactly that. We learned from that one, that mistake. So that's one of the things we need to remember. The other thing that we did that was really smart, and this was again ANA and the Cabinet on Nursing Research and the Board of Directors. Eunice Cole called one day. Many of you may have heard this story from me before. But Eunice Cole called one day for the cabinet, with all the Cabinet of Nursing Research. By that time, I was chairing it. And she said, we are going to have to make some kind of compromise. See the timing, October 85. What are we willing to compromise? What will we give up to get into NIH, and what will we not give up? Okay. Now, most of us had been involved in creating the language for the legislation, although I think Jan Heinrich and the Legislative Affairs did most of that. They let us think we were involved, okay? But they were doing most of that. And Eunice Cole said, out of all that language, which you all have been heavily involved in, what would you change? And so we said, what's the most important? What are they most concerned about? Well, they're concerned mostly about the size and what you can do with the size. Because we were at that point $11 million. The next closest institute was 140 something, okay? Big difference. So we said, okay, what about if we change the title and we're willing to settle for a National Center for Nursing Research to start with, but do not change one word of the legislation. And that's what we did. And that got us through, okay? Now, as you know the story of Reagan vetoing, et cetera. But the reason that's important is that then we had all the authorities in the legislation to build all the programs needed for an institute. So as soon as we could get all those programs built, when we got into NIH, we could then go for redesignation for an institute. And it would not be a big deal.
So the $11 million that nursing had at the time, was
Yeah.
that an amalgamation of all kinds of funding from NIH, or how did that?
No, we had $5 million going into this whole process.
But you knew it was already that was funded stuff.
That was appropriated to the Division of Nursing for research, okay? The difficulty was now, remember, the Assistant Secretary of Health is trying to keep us out of NIH.
Right.
So in the next year, we gained $6 million. We went to $11 million. All of this is a red herring. This is a way of trying to say, stay with us, go away, stay with us, don't go for the NIH center. And to ANA's credit, they never blinked. Now, if they did, we didn't know about it, okay? But they never blinked. They were phenomenal.
And maybe everybody doesn't know, but the Division of Nursing is where we get a lot of support for nursing education, a variety of things. So it was big and important to us.
Yeah.
And has always been and still is.
And still is.
So this was on top of that, it was extra.
Yeah.
So
And as you can imagine, part of the issue is what Dr. Miller's raising is, should we keep nursing all together? Education, research, everything together in one place, and its funding together in one place. But at that time, we did not have that much money. And so it was an issue of, clearly, research is not going to grow if it stays there.
Well, clearly medicine didn't go that way. I mean, medicine was
Yeah.
divided into all the specialties.
We have a division of medicine at HRSA, and then we have all these institutes at NIH with all their diseases, okay? So nursing said, no, not going to do that. We're going for this institute or this center. So literally, President Cole called on an afternoon that I was baking Halloween cookies with my kids. Okay, that's how we get the cookies and compromise kind of statement. I was up to my elbows in cookie dough. My daughter's holding the phone on my cheek until I can get the dough off my hands. And we're talking about, what are we going to compromise? And I'm thinking, how do I get this off my fingers? But so we've always laughed about the cookies and compromise story because of where each of us was at the time that we had to make that compromise. But it worked. It worked beautifully. We went for a National Center for Nursing Research. That was our choice. It was what we were being asked to do by the ANA Legislative Affairs people because they knew from their contact with the Congress that would make it easier. And that made sense, but not a word of the legislation. So we went into this with a name, one name, and with institute legislation authorities. That was critical. And that's something to remember because you always have to do the compromise. And where's that going to be and how much for what? And how do you take the least amount of consequence from that over time, okay? Now, the identification of a champion we talked about briefly. And so you can see all the things that were important there. The window of opportunity was Madigan being mad at the discipline of medicine at that time. We took it. We didn't care why. If he'll front it, we will go with it, okay, at that point. So we had several major representatives in the House, both appropriations and authorization. The Senate, we had 3 different people who were very much on board with this. And the nice thing was to have Mart Hatfield, who was a Republican. The other 2 were Democrats. they tended to get along a little better then anyway. So it was a bit more bipartisan.
And you had Massachusetts and Hawaii. I mean, you had a pretty wide swath.
Yeah, we did cover the country. There's no doubt about that. We did cover the country. And Daniel Inouye, at the point, was moving up to the position of being appropriations chair for the Department of Defense. So I worked with him until his death last December for about 4 years. He's always been a famous friend of nursing. We've been very, very fortunate with him. It's going to be hard to replace him, to say the least. But yeah, we covered the country. We did. Now, the visibility of nursing research was better. Everybody knew it was a good thing. They didn't know what it was or exactly what we did, but they knew it was a good thing. And we've had people like Ada Jaycox and Barbie Hansen, people like that, who've been on the Hill for years before this Cabinet on Nursing Research started doing their thing. But it did make a big difference that they had known us, they'd known some people who were nurse researchers, they knew this was basically a good thing, okay? And we built, for the purposes of the legislation, a network of nurse researchers. Remember, this is before the days of email. So literally, we could call every state in the country in less than 30 minutes with the networks that we had set up to get to all the people who had to be notified if we were going to go for something. Now, nurses notoriously do not write letters. We're doing much better now that we have emails, thank goodness. But we're notorious about not writing letters, and that was still a problem through this. So we did get this established and then redesignated in 1993. The redesignation process, we learned our lesson. The first people we told that we were going to do this was NIH. Okay, not the last person we told, the first person we told. Now, we have been at NIH for a number of years at this point. We've been in there about 6 years. And we have built good collaborative relationships. We've built a good sense of quality, of standards for the research, of being serious about this. I think NIH was not at all serious, knew whether we could be serious about this or not. And we were. So we did a lot of work with educating the other institutes, becoming part of the family of NIH. I even lived on the institute grounds so that I was living next door to other directors, national directors. Because you had to know these people professionally and personally and have all these kinds of political pieces that would work for you. And that was very, very important over time. But interestingly enough, when our professions decided, and it was the Tri-Council again, A&A leading, who decided they were going to redesignate this. Why, when that started with the 1993 reauthorization to redesignate us, I went to Bernadine Healy, woman, you note, who was at that point the person in charge of and the director of NIH. Now, Bernadine Healy, how many of you are in cardiovascular nursing or critical care nursing? Any of you? Okay, yes. Bernadine Healy had wanted to be president of the American Heart Association. And one of the groups that helped her get there was the Council on Nursing in the American Heart Association. And because they had helped her, Bernie was crazy about nurses. Okay? For a doctor. Amazingly crazy about nurses. She is an honorary member of the Academy, all those things that we have done for her. But rightly so. And so because that group of nurses had the forethought to really support somebody that they knew would be good with nursing, that then came back to give us the power base that we needed for the NINR. Because when I went in to talk to Bernie about this, I said to her, the profession now wants to go for redesignating the National Center to a National Institute. We have all the programs in place. Let me tell you about this. Okay, so we qualify on all the fronts, because remember, we had all the authorization to make those programs. And she said, I don't see that it's a problem. We're going to be at this cocktail party, remember cocktail parties in D.C., in 2 days. Let's ask the secretary. And so we were in a reception line with the Secretary of HHS and the Assistant Secretary of Health at that point. And she said to the Secretary, the nursing community wants to redesignate the National Center for Nursing Research as an institute. Are you okay with that? He said to her, it's your decision, and if they're ready, fine. And we walked out of that line with an institute. It's as amazing as that. Amazing as that. I don't have a glass of wine in our hand. Amazing. So we actually got to the NINR reauthorization by two methods. We got to it through the legislative process because we said we're not going to just rely on the executive group to agree with this, okay? Get it in legislation. That way you can't get it stopped easily. And it went through the legislation. But because it also gone through the executive branch from NIH, why, within 2 to 4 days after the legislation was signed, Donna Shalala had a party in her office and signed the legislation, signed the executive branch authorization, and it was done. Very interesting. But because the American Heart Association nurses had been in the right place at the right time, because we had Bernie Healy in place at the right time, we would not have made it with some of the others. We were able to move it. So again, it's kind of that window of opportunity issue that you have to watch for. When's the right opportunity, piece of opportunity to make something move? So it was an exciting time to say the least. Okay? And then signed into operation 2 months, in August with Secretary Donna Shalala. And she has remained very, very invested in nursing, as you know. She chaired the Future of Nursing. Yeah. So it's a fun story because it tells us some of the lessons that we really need to think about. If we're trying to move APNR language next, how do we do that? How do we get every possible organization with the same kind of message? Okay? How do we go about getting things that we're going to need to be able to take care of 30 million more people coming up? How do we use some of these same lessons? Where are the champions? Because we just lost Senator Inouye. So where are the champions? How do we get them on board ahead of time? How do we get all of us unified so we're all saying the same thing? Okay. How do we get the communication in place, which means going to meet with the American Medical Association? And I can tell you I did that with the nursing research legislation when it was moving. It is not a good sensation, but it's okay. You get through it and they get involved. Yeah, at least they have been communicated to. Okay. So even though there are people that you know are going to be against it, you don't want to hide it from them because then they really become obstructionists. You want to step forward and say, this is what we're going to do. Now, they will argue with you, and you can say, I understand your arguments. It will make no difference. This is what we're going to do. Okay? So you've got to be very clear. You're not asking permission. You are telling them from the word go. Okay? But telling them nicely, trying to be sure they're informed, and saying that to them clearly. Mm-hmm.
Students asked me, what difference did that make? And I said, well, it's the same level as the other institutes, but also we got more money funding. But I don't remember what it was, just in the center status and what it went to.
When we started the first year, we had $16 million. We had the $11 million from HRSA that we talked about. And Carl Purcell, who was on the Appropriations Committee for the House and from Michigan, he had a really good School of Nursing research group at Michigan. And so they gave us another $5 million. And another couple years later, we started the Centers Program under Congressman Purcell, and that gave us another $10 million kind of thing. Otherwise, we were getting increases. And we were at NIH, remember, during the time that they doubled the research budget. And the thing I was always amazed about with NIH was once we were there, even though they hadn't wanted us, once we were there, we were part of the family, and we would be good, and we would be treated the same way. And I'll never forget that. I mean, that was really ideal. We were also very careful never to talk about, ha, 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 we're here. I mean, none of that ever occurred. We simply said, this is what nursing research is. Let us tell you about it. Let us get you involved with us on collaborating and funding grants. This is what we want to accomplish. We want our science to be no less than the science that's at NIH. and we have the same standard you have. And that was very important to give those messages very clearly.
In the early 90s, there were some nurse scientists and researchers who actually published in the New England Journal of Medicine, JAMA, for example, at JAMA, the transitional studies for heart patients by Mary Naylor, and of course the transitional studies on NICU patients, the early discharge patients.
Exactly.
By Bruton. What is your assessment of the importance of those publications by nurse researchers during that time as you were battling all this political things?
Yeah. That was very critical because remember we started in 86. I was there by 87, so I can only recount my particular piece of that. And our people began deliberately, our nurse scientists deliberately began to publish in the major medical journals. And that was done, as you know, specifically so that we could, in fact, talk about the quality of the research, talk about the science, etc.
And they talked about cost savings, like the early NICU discharges, how many millions of dollars are saved with the care of the clinical nurse specialists versus the old method of discharging them like 3 weeks.
Exactly.
Later. So they were talking money here. Naylor study did the same thing. So
Yeah. You have to remember, NIH thinks money is crass.
Yes.
Except for when they get it or don't get it for grants. But they think money is crass. So you don't build economic income outcomes into NIH studies. Now we did because that made sense. They were things that we understood that there was a real linkage between the quality of the outcomes you were producing and the economic outcomes you were producing. I'm right on with you. But we did that with NIH not really interested, okay? There was a lot of question about whether we ought to be doing that. And I can remember that discussion in the field as well. But I can remember being at one of the times that we were getting ready to go for the testimonies in Congress. Because every year we had to go in front of the congressional committees on appropriations. And during that appropriation time, we had to be talking about our institute and the research it was doing. And before we went to the Congress to testify, we had to testify in front of Dr. Weingarten, who was really picky. So we would choose, Jan Heinrich was phenomenal at this. She was really good. And we would choose the studies that we knew would get the biggest impact. And one of them we gave one year was Dorothy Bruton's study on prematures and what else that happens with the taking patients home earlier with APRNs. And we chuckled about that one because we got to there and we talked about this study. And I said, you may have read this study. And he said to me, no, I don't usually read the nursing journals for my bedside reading. And I said, well, this one's in the New England Journal of Medicine. Total silence. Total silence. Okay, he says. And we went on to the next subject. But after that, he walked out saying to his colleague who was with him, because she told me later, saying to his colleague who was with him, they may make it after all. I mean, what can you do? Yes.
Dr. Hinshaw, how did you get from Kansas to being one of the Young Turks that was involved?
One of the Young Turks that I was a Young Turk. We all were at that point, to say the least.
How did you personally get involved?
Interesting. I had been at University of Arizona where I went to do my nurse scientist degree. Remember, we talked about that earlier. And went from my nurse scientist degree right into a position with University of Arizona, an associate professorship, and climbed their ladder. In that process, I got interested in nursing research nationally. And so I did a lot of speaking, and I worked with a lot of task forces, and I ran for the Cabinet on Nursing Research, got roundly defeated first time around, okay? But the second time around, it worked. And so I got elected to the Cabinet on Nursing Research. And most of that is because of the research that I was doing. I was doing work environment and nursing outcomes kind of research at that point in time. And people had gotten very interested in that. And so most of that was where I made my reputation as a Young Turk. But I did huge amounts of speaking on nursing research. What was it about? I don't think there's a Sigma Theta Tau chapter in the country I haven't spoken with. Okay? But that's how you learn the issues of what's really of concern to people. And so when I had an opportunity to go to NINRs as director, or NCNR at that point, I had a really good sense of the country, what the issues were in nursing research, because I had done so much speaking and so much work with different chapters and different conferences that I'd heard a lot of that, and that was important. That was really important. It also meant that at NIH, the National Center played the game at NIH very well, but we played it quietly. And we never changed our allegiance from the supporting professional organizations who were our base. So NIH always knew we had a very strong political base because we had all these professional associations, and we never lost track with that. That's when we put together the association that they have now, where all the different associations come together with Pat Grady and talk about nursing research and what's needed and how to support it and so forth. We put that together way back early because we wanted to maintain that whole base of support that was really critical in that sense. I never had to use that except one time, which you would appreciate, because as deans we know how tight space is, any place, every place. And I can remember one time the NIH saying to me, this is a really good place, but we have another building we'd really like to have you think about. And that one was off campus, okay? Move the nurses off campus, you got it? I looked him straight in the eye and I said, I don't think you want to do that. Not with nurses. Never raised again. I never had to raise it, they never raised it. But we didn't get moved out of the place that all the other directors were. And that's the kind of hardball you play sometimes when you have to play it. You don't overplay it. You don't play it anymore and you have to. Yeah. Yeah.
I think too, growing the institute's reach so that a lot of different people served on study sections, got involved in the programs, and that also really helped.
Oh, it did.
We had a lot of people.
Did. Yeah. And that was all very deliberately. Oh, excuse me. All very deliberate, as you know well. Because as a government employee, you never talk with people who are in any of the professional associations. That's a lot of hooey. I mean, I'm sorry. We spent all our time talking with people that were in the different associations. You just did it quietly, on the side, what we call in the government under the table, so that you could be sure that you had everybody involved with you and were going in the right direction, that this was what your profession really needed. We weren't there to grow nursing research for us. We were there to grow it for the profession. And that was very, very critical all the way through. Yeah. I think I'm running over time, guys. It's just about time. But thank you.
Fun story to hear.
It is a fun story. There's some really important lessons here.
Oh, incredible.
There really are.
Just incredible. And it is like the stars were aligned. It's
Yeah.
just,
And that
it's
window of
able to
opportunity.
pull that off. It's just incredible.
The window of